Good afternoon. My name is Inez Ponce, and I'm the director of the UCLA Center for Health Policy Research and professor and Wasserman Endowed Chair in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. As a land-grant institution, we would like to begin by acknowledging the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is the Los Angeles Basin and South Channel Islands. But before we get started, I wanted to take a moment to acknowledge the current situation with federal research funding and UCLA. As you are most likely aware, UCLA, with the support of the UC Office of the President and the Board of Regents, is actively evaluating all options and contingency plans. The suspension of our federal research funding is not only a loss to the researchers, the students, the staff who rely on these critical grants, but it's a loss for Americans across the nation whose work, health, and future depend on the groundbreaking work that we all do. We at the CHPR are pushing on with generating and sharing knowledge to inform policies that will improve health for all. Thank you for joining us. Today's webinar is a bit of a departure from our typical monthly seminars, but we think you'll find it just as interesting and important. We're going to learn about off-label prescribing, which is when FDA-approved medications are used to treat conditions that they are not approved for. The practice is widespread in the United States healthcare system, despite the fact that some of these drugs have not been widely studied for these off-label uses. In fact, about 1 in 5 prescriptions written are for off-label use, most commonly when FDA-approved treatments have not worked or do not exist. I think the question is, though, but at what cost? To better understand off-label prescribing, we're going to focus on Trazodone, a drug approved in 1981 to treat depression, to examine broader issues surrounding off-label use and spending. So Trazodone will be the drug featured. Although only approved to treat depression, Trazodone is often described to treat sleep disorders, such as insomnia. Leading us in our discussion will be Dr. Srikanth Kadiyala, a senior economist at the UCLA Center for Health Policy Research and an adjunct assistant professor at the UCLA Fielding School of Public Health. Srikanth and his co-authors, UCLA PhD student Matt Chenoweth, who's here, and Dr. Jonathan Watanabe, who I think is also here today, Associate Dean of Pharmacy Assessment and Quality and a professor at the UC Irvine School of Pharmacy and Pharmaceutical Sciences, recently had a study about off-label policy and spending published in Health Affairs Scholar. Using data from the 2019 Medical Expenditure Panel Survey, researchers found that approximately 24 million prescriptions were filled for Trazodone at a total cost of $294 million in 2019. Off-label use of Trazodone for sleep disorders accounted for nearly $195 million of that spending, despite the fact that Trazodone's effectiveness on sleep is still unknown. Next slide, please. Okay, next slide, please. Before we begin today's presentation, I want to mention 2 upcoming events. Thank you. On Wednesday, September 10th, we will host a webinar featuring findings from the new California Elder Index dashboard, which provides a county-by-county breakdown of the actual cost of living expenses for older adults, as well as 2 fact sheets that will be released later this month. And then, save the date, Thursday, October 9th, for one of our most anticipated events of the year, the annual release of the California Health Interview Survey. More details will be announced in the coming weeks. As a reminder, today's webinar is being recorded and will be posted to our YouTube channel in the coming weeks. If you would like a copy of today's slides, please email our communications department at healthpolicy@ucla.edu. healthpolicy@ucla.edu. Thank you again. So let's do the next slide, Shrikant. Oh, okay, it's fine. For joining us today. And now I'd like to turn it over to my colleague, Dr. Srikanth Kadiala.
Thanks, Inez. Thanks, everyone. So the title of this talk is Improving Off-Label Policy Through the Lens of Trazodone Usage and Spending in the United States. As Inez mentioned, this is joint work with Matt Chenoweth and Professor John Watanabe. Matt's a graduate student at UCLA in the Department of Health Policy and Management, and Professor Watanabe is he's the head of chair of pharmacy at UCSF. So the structure of this talk is we're gonna first define on-label and off-label use. We're gonna briefly discuss a few historical examples, good and bad. Then we're gonna talk about Trazodone, which is the drug we focus on today. Off-label use has been studied for over 30 to 40 years at this point, and there have been numerous previous proposed policy solutions to address off-label use. We're not going to spend too much time, but I just wanted to highlight some of these previous proposed solutions. And then we will discuss sort of three newish policy solutions that John, Matt, and I propose. So what is off-label prescribing? To first define off-label prescribing, we'll define on-label use, on-label prescribing. On-label prescribing is when a medication is prescribed for an indication that's been officially approved by the FDA, Food and Drug Administration. This approval is typically based on rigorous safety and efficacy standards demonstrated through clinical trials. Now, off-label use is defined as when a medication is prescribed for an indication, patient population, or dosage that has not been approved by the FDA. So, for example, a drug is approved only for depression, but is now prescribed for insomnia. Now, it might be surprising when you first encounter off-label use. It's surprising because pharmaceutical firms usually have to go through these intensive phase 1, phase 2, phase 3 trials. They have to invest significant resources to get a drug approved by the FDA. But once it's approved, physicians can prescribe the drug for how they see fit. So it's perhaps surprising, but there are kind of two or three key reasons for why off-label use occurs. The first reason is that there are cases where there are just no on-label treatments that are available. So this actually happens quite frequently in special populations such as children and pregnant women who are often excluded from clinical trials for safety reasons. A second reason that off-label use occurs is that when on-label treatments have been tried and have proven unsuccessful. So at that point, physicians and patients consider other options, and these are typically off-label options. Now, a third important reason that off-label use occurs is actually clinical experimentation and innovation. Now, clinicians are allowed to explore potential health benefits based on observational studies, theoretical mechanisms, or the emerging scientific literature. Now, this mechanism is actually quite prevalent. This can lead to new discoveries, but also to widespread use of treatments with unproven effectiveness. And we'll describe a couple of the case studies we examine. A couple of examples. We'll describe a couple of examples related to experimentation and innovation. Now, in terms of legality and reimbursement, it's legal. Physicians and other prescribers are legally permitted to prescribe off-label based on their clinical judgment and available scientific literature. In terms of reimbursement, private and public insurers reimburse off-label treatments, usually based on drug compendia and peer-reviewed literature. So compendia, there are a few of these. Compendia are usually put out by physicians and pharmacists and other scientists. And these compendia describe the evidence regarding the efficacy of the existing evidence regarding the efficacy of off-label treatments. So in the case of Trazodone for insomnia, the compendia will review the evidence regarding the effectiveness of the Trazodone for insomnia, and they'll sort of give a rating about how effective they think Trazodone is in treating insomnia and how good the evidence is regarding effectiveness. Once a compendia gives a rating above some certain threshold, Medicare and Medicaid will typically cover it. Medicare in particular will also cover based on peer-reviewed literature. And so it's not always true, but for sure, when these things are included in compendia, they get covered. So in terms of the ultimate goals of off-label policy, the goal is to provide safe alternatives when on-label treatments are not an option, and to provide an avenue for patient-centered innovation and treatment that supports improved care. Now, these two goals, they imply that relatively low use, low spending cases where evidence regarding effectiveness is unknown and uncertain are sort of reasonable outcomes. But they also imply that high use or high spending cases where evidence regarding effectiveness is unknown or uncertain, they should be addressed in this system. Now, as I mentioned, off-label use has been studied for over 40 years. I think in the last 20 years with new data sources, it's typically been studied more systematically. And one of the first papers on this, Bradley et al. In 2001 survey of US office-based physicians, they found that 21% of prescriptions were off-label. Of evaluated prescriptions were off-label. They study, if I'm remembering correctly, they study the top 100 drugs, and they also sample another 55 drugs, top 100 utilized drugs, and they also sampled another 55 drugs randomly and present statistics on off-label use on those 155 drugs. And they find that 21% of prescriptions are off-label, and they also find that approximately 70% of this 21% are off-label without solid evidence regarding effectiveness. So about 15% of total prescriptions, at least in 2001, were off-label without good evidence. And off-label, the other sort of broad fact is that off-label utilization varies based on disease, treatments, and time period studies. For example, off-label treatment is much higher in cancer and mental health. Now, just sort of highlighting some interesting examples, historical examples, a beneficial example of off-label use relates to Avastin. Avastin was initially FDA approved to treat various cancers, colorectal cancer. At some point, physicians began to use Avastin off-label to treat macular degeneration. And they started doing this because during this period, Lucentis, another drug, which is Lucentis, another drug which very similar to Avastin, was going through the phase 1 through phase 3 trials of FDA. And Lucentis was shown to be effective in terms of treating macular degeneration. And because in their judgment, Avastin was so similar to Lucentis, even though it didn't have approval to treat macular degeneration, physicians started using Avastin. So a key difference between Avastin and Lucentis in this case is that Lucentis is approximately $2,000 per injection, while a single dose of Avastin costs about $50. So it's the cost to patients are significantly different. A patient getting treated for macular degeneration significantly different if they use Avastin for Lucentis. Now, in this time period, this was sort of 2005, 2006, 2007. I believe approximately 50% of physicians were using Avastin and 50% were using Lucentis. So one question is, why didn't everyone use Avastin? And the reason for that is that Avastin wasn't created to treat macular degeneration. And there were slight differences in terms of the size and weight of the molecule. So Avastin is created to treat cancer. It's not sort of created to be injected into the eye. And so for at least 50% of the physicians, there was uncertainty about whether they should be using Avastin um, to treat macular degeneration. So around the late 2000s, the National Institute of Health funded a large-scale head-to-head randomized control trial to compare the efficacy and safety of Avastin versus Lucentis. So the outcome of this trial, it demonstrated that Avastin was similarly effective and safe as Lucentis for treating macular degeneration, but a fraction of the cost. So in this case, there was uncertainty, and the uncertainty was resolved by a randomized control trial, and off-label use was shown to be sort of similar, effective, and safe compared to the on-label treatment. And you saved sort of billions of dollars. Now, in terms of examples where there's significant risk and uncertainty, there's some two well-known examples are hormone replacement therapy. Hormone replacement therapy was initially approved to treat menopausal women for hot flashes. But at some point, physicians started prescribing HRT off-label for the treatment for prevention of coronary heart disease. There was enough interest and utilization of HRT for coronary heart disease that there were randomized control trials conducted, and the trials basically showed that HRT increased incidence of coronary heart disease and breast cancer. So relatively healthy women were prescribed HRT because physicians believed that it would help with coronary heart disease, but the trials actually showed that these women were being hurt. Similarly, low-dose aspirin prescribed off-label for primary prevention of cardiovascular disease in older adults. So this is the baby aspirin. And at some point, researchers did a clinical trial, and they demonstrated that it actually increased major bleeding risk without any net clinical benefit in this population. So pretty innocuous low-dose aspirin, but the end result is actually it was on net hurting patients. So our focus today is on Trazodone. So why do we look at Trazodone? So Trazodone was approved in 1981 for a major depressive disorder, and researchers found that increasingly over the 1990s and 2000s, it began to be used off-label for insomnia and anxiety. Now, if you look at the literature, even now, there's significant uncertainty about whether physicians believe that it's effective for insomnia. In addition, the high purported utilization also suggests potentially large aggregate expenditures. So making it a sort of an ideal case in our mind to explore broader issues related to off-label drug use and to propose sort of some policy solutions. So in our study, we looked at sort of three questions. What is the rate of off-label use of Trazodone in nationally representative data? A lot of the previous work in Trazodone was mostly focused on from the side of insomnia. So these papers would primarily look at patients diagnosed with insomnia and then look at what Trazodone utilization looked like. These are usually in claims data or physician office visit data. So I would say both of those have some limitations in terms of understanding the full scope of Trazodone in the nation as a whole. Now, we also look at the total off-label spending on Trazodone, and we look at this for two important reasons. So one is that total spending provides a really important benchmark for evaluating the cost of generating evidence generation from a randomized control trial. So we have some data on what it costs a drug that's been approved by the FDA, what the randomized control trials for those drugs cost. So if you have some estimate of spending, you can get a sense of how far off you are from this sort of evidence generation process. And it's also important to, the total spending on Trazodone is also important for understanding the opportunity cost of care. And some prior work has looked at off-label spending, but I think what's interesting about this work is that we look at spending for a specific drug, which I think in prior work, they've primarily looked for categories of treatments. And I think just for this reason of if you actually have the spending for a specific drug, it's much easier to compare to the benchmark of what's the cost of generating evidence from a randomized control trial, which you can't do when you have estimates for a category of treatments. And finally, we also look at how reimbursement compares for on-label and off-label trazodone uses, which again is previously unstudied. Now, how do we do this? We look at this question using nationally representative data from the 2019 Medical Expenditure Panel Survey. The Medical Expenditure Panel Survey has been used for about 25 years to study all types of health economics and health policy questions, but surprisingly, it hasn't been used very much to look at off-label use and off-label spending. And it's particularly surprising because MAPS data uniquely links prescriptions to diagnoses, which allows for on-label versus off-label evaluation of the prescription level. Now, this linkage is actually, it's quite difficult to get in publicly available data, and especially at sort of a national level where MAPS data keeps track of refills of prescriptions that happen outside of office visits. So in that sense, MAPS data is quite comprehensive compared to other data sources where off-label use has been looked at in terms of claims data or even something like the National Ambulatory Medical Care Survey. So we use the MAPS data, which has this amazing linkage between prescriptions to diagnoses, and we do some pretty straightforward calculations. First, we categorize prescriptions as on-label or off-label. We calculate the trazodone off-label utilization rate. We calculate total off-label spending on trazodone, and then we look at reimbursement for off-label versus on-label uses of trazodone. So what do we find? So what we found is that in 2019, there were about 24 million trazodone prescriptions that were filled by patients. This is a top 25 drug in terms of total prescription fills. We also found that 85% of these prescriptions, approximately 20 million, for off-label indications. In terms of off-label use, the primary indication is insomnia, which is sort of 74% of the single diagnosis prescriptions were for insomnia. Another sort of common off-label use for trazodone is anxiety. So our calculations, based on our calculations, we have roughly in 1 year, we have about 15 million prescriptions for insomnia. Although we didn't look at this in our data, but this would roughly translate to about 5 million patients a year who are getting trazodone and expecting some benefit with respect to insomnia. In terms of total healthcare spending on trazodone, we found 294 million in 2019. The off-label spending was roughly 84% of this total, which is 247 million. And then just off-label spending on insomnia as a whole is 195 million. In terms of healthcare reimbursement for on-label versus off-label uses, we adjusted for differences in payer and medication strength because differences in payer in terms of what Medicare reimburses for trazodone is different from what private insurers and Medicare reimburses from trazodone. And we found no statistically significant difference in reimbursement between on-label and off-label uses of trazodone. So what do our results imply? So we think what we've shown here is a clear inefficiency, right? The results suggest a clearly inefficient equilibrium where substantial utilization and spending occurs without evidence of clinical benefit. Millions have been treated with trazodone expecting a positive outcome of sleep, but we really don't know for sure whether it works or not. Now, the calculations also imply that trazodone's been diffusing over a 20-year period. So it's been diffusing all through the 2000s, and then it's diffusing over the 2010 to 2019 period. So the calculations, if you just do some back-of-the-envelope calculations, they would imply that society has easily spent more than $1 billion on trazodone, the treatment of insomnia, just in the 2010 to 2019 period. This would just be a very conservative estimate, but you could easily reach $1 billion on trazodone. In terms of what we mentioned, it's interesting to look at spending because it gives us a sense of what to compare to in terms of the cost of generating evidence. So some previous studies look at this and they find that in a drug that's been typically approved by the FDA, the cost of running the randomized control trial is approximately 20 million. So even in just 1 year, society as a whole is just in 2019, you're spending about 10 times more on a drug than the cost of generating the evidence regarding effectiveness, which again seems wrong. So why does this? So why does a case like Trazodone exist? So one of the key issues is that there's little to no high quality clinical evidence that supports the effectiveness of many off-label uses. For example, Trazodone for sleep. Now, why does this happen? One reason this happens is that pharmaceutical firms have mixed incentives to generate evidence for off-label indications, especially for generic drugs with multiple manufacturers and absence of patent protection, which Trazodone is an example of. A second reason is that there's as Trazodone has diffused, clinician researchers, physicians are very interested to know whether Trazodone works. So over this time period, there have been many small sample trials, small sample studies done to evaluate the effectiveness of Trazodone. But because these trials usually have approximately 50 to 60 people, the results from these trials, they end up introducing more confusion regarding effectiveness rather than really resolving this question of does Trazodone work or not. So there are a lot of other reasons you can think of too, but following up on these two reasons, the consequence is that uncertainty persists, leading to potentially ineffective or harmful care. And another consequence is that society continues to spend hundreds of millions of dollars on treatments with unproven or uncertain value. Now, I also want to introduce another piece of evidence here is that over this time period, there have been many cases of firms paying fines for promoting the use of off-label use. So these are this is sort of Pfizer, Abbott, GlaxoSmithKline, Johnson & Johnson, Amgen, Bristol Myers Squibb. These are sort of big companies, pharmaceutical companies. And you can see the fines here. So these are sort of 2.3 billion for Pfizer in 2019 for promoting Bextra. And so I forgot to mention that off-label use is legal, but firms are not allowed to promote off-label use. So all of these firms were they settled for promoting off-label use of these. So the amounts are staggeringly large. So 2.3 billion for Pfizer, 1.5 billion for Abbott, 3 billion for GlaxoSmithKline, 2.2 billion for Johnson & Johnson. And so what ends up happening in this case is that there is this sort of other backdoor channel for firms to get reimbursed for the use of off-label use, which again further disincentivizes the evidence generation process, at least from the firm side. So we're gonna quickly discuss a few of the previously proposed solutions to off-label use. So there's a bunch of work that proposes FDA regulations on improved off-label data on off-label use. You might have noticed that the sort of the study that's cited best, that's most comprehensive to some degree, is from 2001. That's because it's not straightforward to evaluate off-label use. So there've been a few proposed. So one of the things that people propose is that we want to improve data collection and potentially label, just as on the label for medications now, there's information on effectiveness and side effects, includes some labeling regarding off-label use. But both of these proposed policies or proposed changes, they don't necessarily solve the evidence generation problem. In terms of broader policy recommendations, prior recommendations have also focused on educating clinicians on appropriate off-label use. There's some work that that shows that clinicians aren't really aware whether a treatment that they're prescribing is off-label or on-label. There's some policy recommendations around modifying malpractice law to address off-label prescribing. And finally, also some policy solutions focused on making pharmaceutical firms more accountable for off-label use. From my sense of reading this work, none of these have really been implemented, and there's a sort of a longer discussion to be had regarding why none of these have been implemented to any large degree. So in terms of what we propose, so one of the key problems here is we need ways to incentivize and expedite evidence generation. In the Trazodone case, it's clear that it's clear at this point that it's very unlikely at this point that any study will show the effectiveness of Trazodone, given that this has been ongoing for a good 20-25 years. So in this kind of situation, what we recommend is that agencies like the National Institute for Health and the Patient-Centered Outcomes Research Institute should fund more research to evaluate outcomes for high priority off-label uses. So PCORI's mission specifically targets areas of high utilization and low evidentiary support, making it well suited to address gaps like Trazodone for insomnia. And we already highlighted this example previously. There was an RCT funded by the NIH was instrumental in evaluating health outcomes related to the off-label use of Avastin in the treatment of macular degeneration. So this has been done before, and this seems like a fruitful area in terms of evidence generation. A second sort of something else we propose are insurer-led trials, right? So given significant health plan spending on off-label uses, insurers have a strong financial interest to conduct RCTs to evaluate effectiveness, right? This has rarely happened before, but there was one example where insurers previously provided funding to evaluate the effects of autologous stem cell transplantation as a treatment for breast cancer. So in this case, based on our calculations, even a modest reduction in Trazodone, like in the case that Trazodone is found to be ineffective, even a modest reduction in utilization could justify the cost of a trial. If the drug is found effective. If the drug is found effective, then that's great. Then everyone, patients, and clinicians and insurers know at that point that the drug is effective and should be widely used. It's unlikely that any small insurer would fund such a trial, but you can imagine that some of the large insurers sort of forming some sort of consortium where they could fund RCTs into specific treatments, particular treatments. The second proposed solution relates to pharmaceutical pricing. So roughly the way that pharmaceutical pricing works is that the FDA approves a drug, and once the FDA approves a drug, private payers and the pharmaceutical company negotiate regarding the price of the drug. And broadly, the price of the drug is dependent on factors such as how many patients are potentially likely to use the drug, what competitors are available for in terms of what the drug is treating, and information regarding the effectiveness of the drug. So these high-level factors influence the initial price that's negotiated once a drug is approved. Now, if that's the case, then it seems logical that the prices for drugs that are used off-label for indications alone should be lower than for approved on-label uses. And again, going back to what are the sort of the two negative consequences, potential negative consequences of off-label use that we want to address. One is uncertainty regarding the evidence about effectiveness, and the second is total societal spending on something that we don't know works. And sort of reducing prices for drugs that are used off-label would address this sort of second problem with off-label use. Similarly, we propose that Medicare also negotiate drug prices based on off-label use. This has been a recent Medicare until the Inflation Reduction Act. Medicare was not allowed to negotiate drug prices. They was sort of based on the price that private payers negotiated. But starting in 2023, Medicare began negotiating prices for 10 drugs in 2023. They're supposed to expand to 15 drugs in 2025 and 20 drugs annually from 2029 onwards. So this is an opportunity for thinking about how the on-label versus off-label use, especially off-label use, where there's no evidence regarding effectiveness. This is another opportunity to include that factor in the price setting process. And finally, I think over the last 20 years, there's been a lot of interest in value-based reimbursement. And so the idea here is that reimbursement for off-label drugs without proven benefit should be lower. And as we showed in this work, off-label uses of Trazodone and on-label use of Trazodone are reimbursed by the same amount. At least in the case of generics, one drawback from this type of policy is that it may negatively impact pharmacy profits and viability, especially for generics like Trazodone, which are already priced at near marginal cost. So to conclude, off-label prescribing, particularly for uncertain or low-value care, contributes to wasteful societal healthcare spending and can negatively impact patient outcomes. The current approach does not support evidence-based improvement in care informed by off-label use. As we show in the Trazodone case study, millions of prescriptions are written each year, even though effectiveness is unknown. And in just 1 year, approximately 195 million specifically is spent on off-label Trazodone for insomnia. And we get into this a little bit in the paper, but you can also get a sense of this from reading prior work in this literature, some really interesting work by Walton and Radley and Alexander. We don't think this case, we don't think an example like Trazodone, it's not uncommon. So in that sense, this is an issue that's worth thinking about. And our paper proposes 3 implementable policy solutions, leveraging modern data sources to foster a more efficient system of off-label use. Thank you.
Good afternoon, everyone. My name is Tiffany Lopes, and I'm the Director of Communications at the UCLA Center for Health Policy Research. I've been posting some links and things in the chat. We're going to get started on audience Q&A. So if there are questions that you have, please use the Q&A function in Zoom to ask them. So let's get started. Actually, Shrikant, can you stop sharing so that we can get everyone up? And then we are also joined by Matt Chenoweth, a PhD student at the UCLA Fielding School of Public Health, who will help with audience Q&A. Matt, can you turn your video on, please? Thank you. All right, let's get started with the first question. What constitutes promotion of off-label use? Is it only promotion directly to clinicians and prescribers, or does it also include direct-to-consumer promotion?
So my understanding is that direct-to-consumer promotion is not allowed. So as you see ads on TV or online regarding the use of pharmaceuticals for different conditions, if you don't have an indication, you're not allowed to promote that directly to consumers. I think in the case of physicians, it becomes it's more complicated. Physicians are allowed to request information from firms regarding off-label uses and evidence regarding the effectiveness of off-label uses. And when they are requested, I believe then that firms are allowed to discuss these. But firms on their own are not allowed to mislead, or they're not allowed to, I believe, volunteer information. That's my understanding of what promotion of off-label use is. Matt, what do you think?
Yeah, if I can chime in to expound on what Shri said, the regulatory standard at hand is the intended use doctrine, which is predicated on the idea that any form of communication taken in context would be viewed as intended to promote a use not on the FDA-approved label. So in that context, it could capture marketing to clinicians or DTC, or I'm dating myself a bit with this reference, even the indirect promotion channels, like things like paying influencers or social media posts, things of that nature.
Thank you both. The recommendation for insurers to support trials to produce evidence about off-label use seems promising, particularly given current uncertainties around availability of federal funding. Might there be additional ways to incentivize insurers to do this beyond the potential for reduced reimbursement in the event evidence suggests a drug is not effective?
I completely agree that in this current environment, the evidence generation from in terms of NIH, it's unlikely to that process is unlikely to work. I in terms of what insurers can and cannot do, in terms of incentivizing new trials, I'm not 100% sure. I have to think more about it. But to me, a consortium where a bunch of large insurers are able to pool their resources and fund a trial on an interesting treatment that affects a large percentage of the population, or in terms of what's interesting, I think there are two cases that are interesting. It's either high utilization case where you don't know whether something works or not, or a potentially even a low utilization case where the spending is still quite large. In that sense, I think they're due to me, just conceptually, it does seem like insurers would have incentives to do some trials. But again, I think getting that process started, and I think it's quite a bit of work.
And I'd amplify Shri's note about trying to have a consortium of folks involved, because it's the classic information as a public good problem, that anybody that's going to invest the time, money, and resources to generate rigorous evidence, if it's not directly to their benefit, or if it's something that becomes widely available to other folks, we necessarily know classically that those sorts of goods will be underprovided.
Thank you both. I'd also like to mention Dr. Jonathan Watanabe is one of the co-authors of the paper, and he's joined us as well. And he posted a note in the chat saying, as Shrikant mentioned, the physician can ask about off-label, but that would need to be responded to by company med information professionals, oftentimes pharmacists liaisons that work for the drug companies. So the next question, how do European healthcare systems deal with off-label prescribing?
That's a great question. I think we're interested in this question. I'm pretty sure off-label use is allowed in a lot of European systems, so it does exist. But I think there is a very interesting question of, for example, this is something that we're interested in working on, which is what happened with respect to off-label use of HRT in European countries. I think thinking about cross-country comparisons and learning from other systems seems useful. I think recently I read something about how the French system is trying to incentivize se- use of drugs for secondary indications, and it seemed different than what we do currently. And I think it would be interesting to sort of do a survey of what other systems do and learn from other systems. Yeah, but it definitely
100% agree.
exists. Yeah, yeah.
Yeah, 100% agree. It's an active policy space. And to go back to the foundational question, if developing a novel pharmaceutical is a expensive and time-consuming process, then certainly trying to pursue additional evidence-based treatments based on the existence of those products is worthwhile. And there is, to Shree's point, some international policy variation, which we're going to take a look at.
Great, more studies to come. Are there examples of indication-specific pricing, and has it ever been done before?
That's a great question, Matt. What do you?
May I?
Yeah.
So in general, pharmaceutical reimbursement is incredibly complicated, and we don't have indication-based reimbursement in this country because individual insurers negotiate with pharmacy benefit managers that are agents for pharmaceutical companies. And you can't really accomplish indication-based pricing because if you were then the insurer, that you would then be highly motivated to try and establish the lowest possible price based on different indications. And once you had that, there's no check on whom are you actually prescribing this product to. There would be no way to go back and say, okay, if I have indication A and indication B, one's cheaper than the other, and I'm claiming that all of my patients are in fact the cheaper ones. That said, with that as theoretical background, Shree is co-author on a paper that I'm leading where we are looking at the new fancy anti-obesity drugs, which are the same molecule but have separate FDA approvals for diabetes and obesity management. And given the different willingness to pay for those products, we actually do have early evidence of indication-based pricing. So stay tuned for that paper in the next month or two.
Yeah, and I think just following up, I don't think there's a lot of evidence. I think people have definitely proposed some version of indication-based pricing in the last like 10 years. I think one of the issues is exactly this thing of what Matt is saying is that you worry that you can't control how a specific drug, what indication a drug is used for. But I think there are pricing mechanisms where that is less of an issue. So I think this is something that in terms of how would you implement a price, I think there are different ways of doing it. And they might have sort of different end results. And so I think this is something we're working on. Like in terms of fleshing out what we did in this paper, thinking about how these policies are how these policies might vary in terms of their effects for generics versus brand name drugs that are still on patent. I think there's a lot to work on. It's in terms of how a pricing thing might actually be implemented. Yeah.
If I can elevate
Yeah.
John's comment from the chat, he makes the accurate point that to paraphrase, indication-based pricing in its rawest form is non-coverage for certain conditions, where there may be emerging evidence or there may be emerging utilization, and insurers will make the decision whether or not to cover a product for specific indications.
Right. So there's just to keep building on this discussion, insurers might not cover off-label use. So we know that one path to coverage is through compendia, and another path to coverage is through peer review. But it's also possible that insurers just will not cover in certain cases. Yeah.
So Matt, you mentioned weight loss drugs, and the study that you're working on. We have a question. How has the popularity of drugs like Ozempic and Wegovy, which are FDA approved to treat diabetes, but now commonly used for weight loss, led to any new legislation or advancements in improving off-label prescription use? Or is that more to come?
So specifically to the policy environment, I don't think there's much on the horizon in terms of specific policy changes that we could anticipate. Part of that is the larger environment that I think everyone's familiar with. And then in turn, I don't want to seem too pessimistic, but there could be changes. And then to talk a little bit more about the drugs for obesity and diabetes, what'll be really interesting is one of the things Shri alluded to in a different context is some of those products will be going off patents. So it'll be really interesting in the next couple of years to see how utilization for those changes.
And to follow up on this, I think one of the interesting things in this space, especially in the weight loss, probably a few years ago, maybe less so now, and this happens in other off-label cases, which is that the off-label use in certain situations ends up crowding out the on-label use, which is another feature of off-label use that people have mentioned, but I think has also been understudied. And this for sure happened during the pandemic, where some of the drugs that people were using off-label to treat COVID, or even to prevent COVID, ended up being in a shortage situation because there's the supply of those drugs was already small, and the things that those drugs were actually approved for were there wasn't enough of a supply because they were used for treat COVID. So I think there's some I think there's sort of this is just like a super interesting area and lots to work on.
Thank you. We've got a couple questions about physicians providing or prescribing off-label drugs. When you are prescribed a medication from a physician, do they have to state if the medication being prescribed is on-label or off-label? If not, should this be part of the policy to better inform patients?
Yeah, this is a great question. I think my understanding is that they don't have to. And as I mentioned, there's some work that shows that physicians don't even understand when something they're prescribing is off-label. So in that sense, they might not even be able to convey that information accurately. But I don't think it's a requirement. I could be wrong, but I believe that malpractice laws are different across different states, and I can imagine that a very conservative physician would tell, if they knew, would tell a patient that what they're being prescribed is off-label. But again, I don't think there's a requirement that they have to. Yeah, they're allowed to using their clinical judgment. Yeah, that's a great, interesting sort of ethical and philosophical question too. I think.
I'd add that this entire question also exists in the same care delivery context that John outlined, where you have folks that say they are prescribed a product off-label, it then has to be approved by their insurer, or they'd have to pay significantly out of pocket for it. One of the findings in this paper was variation in who pays for what with respect to what a patient's getting, with respect to reimbursement and out-of-pocket payment. I would add to that in general, we frequently lack good comparative effectiveness evidence for lots of care delivery. So to ask how likely is a given patient to benefit from a particular care at the point of care is often a question that's difficult to answer, and for instance isn't answered in clinical guidelines or in clinical professional society promulgated guidance for how care should be delivered. There's often not a threshold to decide, is one product better than another? I don't want to pretend I'm a real doctor, but that's a bit of the state of play.
Thank you. And then along those lines, how do we as patients know if the off-label prescription has actually been reviewed by the FDA and failed to treat that particular condition versus no clinical trial has been completed or FDA approved?
This is a great question. So right now, you can, as a patient, you can go to the FDA website and try to figure out whether the indication that you've been prescribed off-label is whether the treatment that you've been prescribed is off-label or not. So you can do that on your own. What's kind of interesting about off-label is that there are studies, just exactly like HRT for heart disease, for healthy women in their 40s for heart disease, or where there are good trials. And so there's good information about whether the off-label use is effective, but that you will not be able to get sort of from the FDA. That you'll have to do research on your own through sort of like the scientific databases like PubMed or some other database. So in that sense, and especially the compendia are another avenue to try and figure out what the evidence looks like with respect to off-label, like effectiveness of off-label use. But what's a little disconcerting is that it's very difficult. The compendia are super expensive, and no like a typical person will not have access to compendia. So in that sense, there's some well, the safest, probably most efficient way to gather information is to probably look at what professional societies report with respect to guidelines. But you're kind of on your own to some degree with respect to off-label use as a patient. That's my kind of feeling as I've been thinking about this. Yeah. Matt, what do you think?
Yeah, I agree. I don't think in an ideal world that the onus for evaluating the state of clinical evidence would be on the people who are receiving care. That said, to a point that John had made, there are lots of treatments that we don't have good clinical understanding, either of how they work or the extent to which they work. Maybe there are some where the evidence is anecdotal, or in a product like Trazodone for insomnia, there are small studies that are not particularly determinative, either by demonstrating large effects or having sufficient power to allow you to draw broad sweeping conclusions. So there really is a need for more systematic evidence generation across the board. And I would submit that applies to drugs and a variety of other clinical practices. And if folks are interested, I am only too excited to talk with them about it.
So I just want to thank you both so much for the presentation and for such a great Q&A, and to Jonathan as well, who's joined us in the chat, and we've been copying and pasting and reading some of his comments. Just a reminder to folks, this webinar has been recorded. We will be posting it to our YouTube channel and website in the coming weeks. I posted a link to an email address, healthpolicy@ucla.edu, if you're interested in getting a copy of the slides or want us to let you know when we have posted the webinar. We also have some events coming up that Ninez mentioned earlier. So if you want to know more about those, sign up for our listserv. We will be sending emails about them in the coming weeks. So thank you both and everyone, and have a lovely rest of the day.